Evo, for this introduction, and thank for the organizers for inviting me here. A beautiful Turkey, Antalya. I will speak about a subject which is very much intertwined with mental health disorders in particular, and that is the field of addiction. About a year ago, I was invited for the Dutch Journal of Psychiatry in a special issue to write an article about proactive psychiatry of addiction, let's say prevention, and even at a very early stage to write an article about that. And that's what I did, together with a Belgian professor. And we had, in June, we had a presentation for the United Nations Drug Control Board, and it was very well received. So that's part of the presentation that I will do this morning. I will talk a little bit about substance and substance use disorders, because not everybody is familiar with that. Prevalence and onset, burden of disease, a very important topic in our field, sort of standardization of what the burden of disease is. Treatment demand, and I'm very curious about the Turkish situation, about that also. Risk factors for SUD, which appear to be very similar to those for other mental health disorders like schizophrenia or depression or anxiety. Self-regulation, I think that's a very central endophenotype for many, many disorders in life, so I will go more in depth about that. And I will end with the prevention and early intervention, and really early at an early age, even in childhood. And I come to some implications of it. So first, what are substances about? These are pictures of, on the left, somebody who is a base coke a smoker, MDMA, ecstasy. In the middle, you see an advertisement, an old advertisement of Bayer, of course, the pharmaceutical company, and they marketed in the beginning of the 20th century or end of the 19th century heroin as a medication against coughs. And it works against coughs, but it has also some other side effects, basically. What you can also see on the right, and that's about smoking, is that it was no problem in the early 50s that a person who mimicked a medical doctor with a white jacket on, that he promoted Camel, the brand Camel, as a cigarette type that really did not give any problems as opposed to many other cigarette brands. So let's say the culture has shifted in the past decades, and perhaps also in Turkey, about the health consequences of smoking. Perhaps you're familiar with the criteria in the DSM-5, and that is quite a shift from the DSM-4, where there was a distinction between abuse and dependence in the substance use disorder. But that distinction between abuse and dependence was omitted because what appeared to be is that the 11 criteria of SUD, substance use disorder, actually formed a unidimensional scale. And a unidimensional scale means that very likely the criteria counted, so to speak, form a unidimensional scale that represents severity. So the more criteria you meet, the more severe the substance use disorder is. Basically, some criteria are about loss of control, which I think is the key of addiction. The next three criteria about social limitations, so narrowing of a repertoire, for example, at-risk substance use, and finally physical dependence, as indicated by tolerance. So you need gradually more of the substance to experience the same effect, or withdrawal symptoms when you cease the substance use, or you use substance use to avoid withdrawal. Substances can be sort of classified in all kinds of types, but this is the most common classification into sedatives, into stimulants, and into hallucinogens or psychedelics. In red, you see some substances that are most used in the Netherlands, so in the country where I come from. Of course, the legal substances like alcohol. Let me see if this is, oops. Alcohol, nicotine, caffeine. No, doesn't work. But also ketamine, which is really on the rise in the Netherlands, also and other hallucinogens. Okay, thank you. Yes, works much better. Mushrooms, cannabis, many young people do not know that cannabis is a psychedelic. They think it's a sedative, and of course it has some sedative, relaxing and stoned experiences, but it's actually psychedelic. Okay, about the prevalence, and I'm quite curious about your own country. In the Netherlands, and that is very similar to that of the United States, the lifetime prevalence of substance dependence, so let's say the more severe form of substance use disorder among adolescents, most that I talk about is about young people, so adolescents, in the general population is quite similar. And these are some categories that might meet yes. Do you have any idea about the prevalence of substances, well, let's say in the Netherlands and in the United States, or perhaps even in Turkey? Are there any general population surveys done in this country? No? Dependence. So let's say in DSM-5 terms, moderate to severe substance use disorder. In the population, so let's say the general population. What do you think? Make a guess, a guesstimate. How much? 4 to 7, I hear.
4 to 7, yeah.
Could be. You have any idea, Ineke? Okay, let's see. It's about 7%. And I think that's quite much, because that means that 1 in every 14 adolescents in this short lifespan meets the criteria of more severe substance use disorder. But that's quite something, I think. What about your country? Okay. Are there no data available in Turkey at all, or? No. Are there any surveys done?
But I thought it's 10% or something.
Oops, that would be
Well, I assume it will be much lower than that. But there is this aerosol addiction is quite common in certain areas of Istanbul, especially.
Okay.
Yeah. But I assume it's lower than this 4 to 7.
Okay.
Be around 4.
Yep. Well, that's what we know with the addictions worldwide. Epidemics come and they go. I mean, think about the opioid, prescription opioid epidemic in the United States, which causes more deaths than firearms and traffic accidents combined. It's unbelievable, but epidemics come and go. Now, in our country, heroin used to be an epidemic in the 1980s and 1990. But now it's on a low, on the low side. So, and sometimes it pops up again. And it's difficult to predict which substances cause which epidemic. Want me to go back? Yeah. Yes. So is it which substances are involved? Kato asks when you're talking about addiction, about substance use disorder. I will tell on the next slide. Very good question. This is, well, basically in our country, up to so far, the only general population survey that was done among adolescents. And what you can see is, I was quite surprised that among the 3 major classes of disorders, mood, anxiety disorders and behavior disorders. And behavior disorders, let's say conduct disorder, oppositional defiant disorder, and ADHD. That the prevalence of lifetime, and lifetime is only short, right, during adolescence, is not 50 years or some. It's really, especially for substances, it's quite a short period. So these are quite high lifetime prevalences. And exactly what Kato just asked, alcohol abuse, when you're a student, when you're an adolescent, it's quite easy to meet the criteria of abuse. You hop in and out of it. So that's why I think that dependence is a more sort of robust indicator of addiction in a society. This is the 7% I just talked about, and it's basically a combination of alcohol and drugs. But drug dependence, also various substances, is 4.5%, and alcohol dependence is 3.2%. So drug dependence is even higher than alcohol among youth, which is not surprising. The majority is cannabis, of course. Yep, yep. Is that in Turkey also? Is cannabis here one of the most used substances by young people?
It is one of the most.
One of the most?
One of the
okay.
most, yeah, cannabis.
Yeah. Okay, what about age of onset, which is an important indicator of all kinds of things. You can say that the earlier somebody starts with substance use and regular substance use and heavy use, perhaps that's a predictor of many bad things in life, many negative outcomes. So it's an important predictor. And when you look at the different mental disorders, including addiction, in this presentation, I consider substance use disorders as a psychiatric disorder. I mean, you can also look from a cultural or sociological point of view to the phenomenon, but I use in this lecture a medical psychiatric point of view. You can see there is a clear order between the various substances. So ADHD, this is the 7% I just showed, and it's harmonized on 100% to compare, let's say, the growth curves of each of the mental disorders. So you can see clearly that ADHD it has a very early onset, and it's even one of the criteria of ADHD that some of the symptoms should be present before the age of 7, I think, in DSM-4, and later before the age of 12, so it's even integrated into the criteria. Anxiety disorders, some anxiety disorders very early in life, like separation anxiety. Are any one of you a child or adolescent psychiatrist? Or okay, well, then that must sound familiar. Conduct disorder, oppositional defiant disorder. After that, mood disorders start emerging, let's say, at a very early adolescence. And substance use disorder dependence is clearly the last in the category. But still, what surprised me in the Dutch study of Ormel is that of the 100% that met the criteria of dependence before the age of 19, then this survey was done, that half of that group is here, so the 50%, half of that group had a lifetime dependence on or before the age of 16. And I was very surprised. This is general population. Yes?
Thank you. Do you have an idea if this changed when the law on the drinking age in the Netherlands changed? Because it changed it from 16 to 18 years?
No, I don't have really information about it, but I don't have information also if that of the prevention campaigns in our country, of Trimbos basically, whether that had a positive effect on drinking. We see a general pattern in our country, but it's now stabilized and again on the rise a little bit, of the past 15 years of a gradual decline of any substance use. So smoking, drinking, hard drugs, inclusive MDMA, which I had not expected. But now the last 2-3 years it's stabilizing and on the rise again. But you never know with prevention, and that goes for the whole presentation that I have here today. It's very difficult to attribute certain changes in the epidemiological data to one prevention campaign. That is difficult. Yeah. I know that the institute that does the prevention campaign likes to interpret it that way. Yeah.
Excuse me, we have one more question, I guess.
Yes.
Merhaba hocam. Bizim ülkemizde
Deneme. Oran öyle mi %10?
%10 herhangi bir yasa dışı maddeyi deneme oranı. İstanbul çalışmasında.
Yani denemeden kastımız bir kere de
Evet
kullanmak.
evet yaşamda en az
Okay.
bir kez deneme.
Okay, so she's like the 10% is the ratio for using a drug for a trial once. But there aren't any studies that shows the level of misuse or addiction. But 10% is a trial that they tried once, at least.
So a trial of young people from the general population?
Yes, from general population, yes.
Okay, so that would be on the high,
Evet 18 yaş altı.
on the high side. Yeah, but then again,
underage,
it could include, if the inclusion was with DSM-4, it could include abuse also, right? So that may be a little bit an overestimate then. Yep.
Evet evet.
Okay,
Evet.
thank you. Okay, this is basically the same picture, but now from Dr. Lee, who published in Science, and what you can see, it adds a little bit information about schizophrenia also. So the dark sides are, let's say, the median peaks of the onset of a certain disorder. That's basically the same as the picture that I showed you. Schizophrenia has a mean onset around 15, 16, 17, 18 years, right? You see that mood disorders also here have a later onset, which starts to even increase in young adulthood. Okay, burden of disease. I decided to include that in this presentation because burden of disease is a little bit a complicated measure, but it's the only really sort of harmonized measure about burden of disease that we have. And it's quite important because burden of disease is often expressed and quantified in terms of, well, the term is disability-adjusted life years. You must have heard that term. It's used more and more. And disability-adjusted life years, the DALYs, they contain two components that are sort of equally important. The first component is the years of healthy life lost due to premature mortality, so just because you die early, because you smoke, for example. Representing, of course, the fatal burden, and the other component is the years of healthy life due to disability, so that you are still living, but you have, for example, lung cancer from smoking. And those two components are added to sort of come to the DALY. And more in lay terms, one DALY can be thought of as one last year of healthy life according to a sort of ideal standard, so that you will become old in old years without any disease and die from natural causes. So a DALY is a term of losing either life years because you die and or because of disability. Well, I thought, what do we think when we look at mental disorders, again, including addiction, and in the literature there are special also DALY calculations of addiction, but this is together with the mental disorders. How much of all healthy years lost due to disability, the years lost to the YLD, can be attributed, you think, to mental disorders, including addiction? How big is that percentage? Mental disorders through a lifetime, so from birth to dying. Is that up to 10% or up to 20 or up to 30 or up to 40 even? Yes?
I think number 3, 21 to 30%.
Number 3, the yellow one.
Yeah.
Okay, who wants to do a guess? What is the place of mental, think also about cancer, cardiovascular disease, accidents, firearms, any cause of life. What is the place, the percentage that are attributable to mental health disorder? You think the red one, okay. Other guesses? I was quite surprised, I already say to you.
I think it's yellow.
Yellow. Okay. I think that's right. Yeah, it's unbelievable. This is, and it's consistent in all kinds of big and good conducted surveys. This is from the famous Victorian burden of disease study in Australia. And they repeated that in 2015, so later still. And they found exactly the same. And for women and men, they found exactly the same pattern. More than a quarter of healthy lives lost due to disability, so not to dying, is purely attributable to mental disorders and addiction. It's unbelievable. And it's, as you can see, it's the biggest proportion of all causes, so much more than cardiovascular disease, cancer, injuries, musculoskeletal diseases, diabetes. It's quite common, of course, as losing quality years. Chronic respiratory disease, mental disorders are absolutely number one, including addiction. I didn't know that, and I was already many years in the profession. Yes. Maybe you can have a microphone? Yeah.
I wonder, is that because diabetes mellitus has treatment well, that's why it's 6%, maybe mental disorders, mostly not cured well.
Yeah. Well, diabetes is not cured, but it's of course treated with insulin, so that people have sort of less problems with it. All the diseases have a sort of rating of what disability score they have. And mental disorders have a very high impact for the person himself, even higher than people with cardiovascular disease, etc. So living with a mental disorder, think with depression, that you don't see anything joyful in life for long periods of life, or schizophrenia, that you're completely confused about what you hear, see, and feel, and that everybody leaves you, basically, in life. That's a very high burden of in your own experience also, in your judgment. So I think that's why mental disorders have such a prominent, or even first place in experiencing disability in life. Yeah.
Thank you.
Yeah. Okay, these are data throughout the whole lifespan, so from birth to death. Next question, in which age group do mental disorders, again, including addiction, contribute most to the non-fatal burden of disease? Is that among young people, including adolescents, the green choice? Or are that the early adults? Or the mid-adults, the yellow part, or the older adults, 60 plus? Number one. Who agrees with number one? I see a couple of no's there. Yeah. Number one also? Okay, let's see. It's number two, and I show you, it's a famous graphic, and it took some time to really believe again what is, so this is the lifespan, so across the whole lifespan, you can remember a little bit that quarter for both males and females that were attributed to mental disorders. But here you see that basically, between 18 and 40 years, that the mental disorder part is most predominant, has a most predominant load of burden of disease of all diseases. So perhaps even here like 60% of the total burden of disease, which is, you know, in these calculations. By far the most important cause of non-fatal disability in the young age group, the early adults. Yeah. So disability is not only very high for mental disorders, but particularly among young people. That's basically what it is. Treatment amount. And these are data These are data from the Netherlands. The Netherlands is a small country with a growing population between 17 and 18 million people. These are data that stem from 2016, and that was unfortunately the last year that we were allowed to collect national data because of privacy law. So after that, we don't have an overview of people that applied for youth addiction care and for other mental disorders, etc. in the Netherlands. It starts coming again, but so we miss for a couple of years this overview. So in total, treatment demand, again, it's a small country, was about 65,000 people that on an annual basis asked for help for an addiction problem. So both adults and youth. And the youth up to 22 years was about 9% of the total treatment demand. So a small 6,000 young people asked for help at the youth addiction care in the Netherlands. Or perhaps I should say, well, some asked for help, but others had to go because their mother said so, or their father, or the school teacher said that, or other people, or the police said that. And that's part of what is difficult with young people in treatment. I mean, any sort of treatment demand is quite ambivalent. People have second thoughts about it. They want to change their behavior, find it difficult. That goes for many mental disorders, but particularly for addiction, because there are also many rewards in addiction, right? And it goes even more for young people, you know, who have to give up, have to acknowledge to themselves they have a big problem in life. That's quite difficult. So we should not underestimate that. Well, what you can see is from 11 to 22 years, so the youth addiction care in our country is free of charge, the whole addiction care, so people who have an addiction problem can go for treatment, and sometimes for years. Yes?
Culture, the different cultures in the Netherlands or anywhere else, does that make a difference in asking for help?
Absolutely, good question. That's a good, so everybody understood, is there a difference between cultures in treatment demand, so in requesting help for a problem? It is, and I think it is from two sides, both from the migrant side, many migrant people from Morocco, from Turkey, from Syria, and lately also from Ukraine. We find much less in all health systems, and particularly in the mental health system. And perhaps even more in the addiction treatment system. And that has to do with cultural, how do you say, stigma. Difficulty of acknowledging that you have a problem. It has to do with shame culture, of course. But it also has to do, I think, from the institution side, that we are not welcome enough, and we are not, how do you say, ready and organized to meet people from different cultures. And there's a lot of effort. Heval knows a lot about it because she's a colleague in my research institute and works exactly on this matter. You know, how to sort of include this broad diversity, men and women. We see, for example, for decades, an 80% men, 20% women difference between asking help, and the women ask for addiction predominantly help for benzodiazepine use. So sleeping and relax pills. Yeah. While for the men it's much more uppers and heroin, etc. That's an important question. Yep. What we see is among these young people, and again with under representation of the migrant population and of women. But we see also that 20% men and women here among the young people, is that about 90% of young people with the addiction problem are 16 years or older. And we have limited our youth addiction system up to 22 years, so a little bit later than the adult age of 18, in order not to, let's say, mix the young people with the adult people together in clinics. That doesn't work. Young people need, you know, another approach than adult people. So that is quite something. Only 11% of the people we were able to reach at the age of 15 or younger. So that's a problem. We do not reach our young people early enough. And if we reach them, they are, well, I should not say an end stage of their addiction, but they have much comorbidity. So it's rarely a short during addiction. They have problems for many years already. They have comorbid psychiatric problems and many other social problems, and then we see them. So there is a lot of damage done already before we get our young people in. So we have to reach them earlier, and that's the core of this presentation. When we see them, and basically they all already show early signs of a chronic intermittent disorder. Long periods of use interrupted with short periods of abstinence or reduced use, and again, a relapse into chronic use. And that's something we have to prevent. We have to cut this mechanism. We have to reach our patients at an earlier stage when symptoms are still mild or transient, so they can appear and disappear, or perhaps even before when there are only precursors or possible dysfunction. Let's look at these precursors. And these are the usual suspects. And they are not only the usual suspect for addiction, but just as much for schizophrenia or for anxiety disorders or for behavioral disorders. So there is a series of bad things in life that can happen that are so damaging that you tend to have a bad life long into adulthood. These are these factors, and there are many more. This is just a compilation. They lay in the area of the broad social context and the institutional context, the environment. Poverty is a famous one. Also in terms of DALI, many poor people die much earlier, I mean like 7, 8, 9 years earlier than people who are not poor. Disadvantaged neighborhood, school, special education, being homeless at an early age is devastating. It's also in a more direct environment of peers, deviant attitude, positive outcome expectancies, or in the direct family environment, parents that don't supervise their children, have poor family conflict or no parental rules, etc. And finally, they're at the personal level. And adolescence itself is, of course, a sort of risk period. When I became a professor of addiction and psychiatry in young people, I thought even about my own grandchildren, I hope you get good through adolescence. If you're okay up to your 18th, 19th, then it's okay in your life. You know, if you start having problems in adolescence, it's a precursor, it's a higher risk of many problems. So I started looking different at adolescence, and it's a risk period. And of course, it's evolutionary. It has a function that children at that age take more risks because they want to know what the consequences are and they want to experience with adult behavior. And sometimes that goes good, and sometimes they make an accident. But they need that in order to grow into an adult. But it's a risk. Okay. I showed a picture 1 second later. If you have to choose one of these many factors that you saw in this schedule, what would you account, and there's not a right or a bad answer, would account for the bulk of addiction risk? Which factor would you choose? Is there something that you would say, well, this is so prominent as opposed to many of the other risk factors, that I would choose that one as that is responsible for the bulk of misery? Okay. Eva, what do you say?
I'm thinking...
You wrote something about genetics, girl?
Exactly, that's, you know me. I was thinking about environment, but in the environment I'll put family factors mostly in.
Yeah, sure. Well, and even genetics, we know from twin studies, right? We know that about 40 to 70% of genetic risk for addiction and for many other mental disorders is attributable to unique genetic factors. Adverse childhood experiences, right? Like sexual abuse, physical abuse, neglect, emotional neglect, very important. Thank you. I will talk about that tomorrow. Yeah. Anybody else? There's not a good or bad answer. Poverty is overshadowing basically everything, is also an important confounder in many studies. Yeah. Excuse me? Social dysfunction. Yeah. Yeah, yeah, yeah. Yeah, absolutely. I agree with all. I choose this one. And not that it's even, well, I think it's such a central, I call it an endophenotype. It's like, it's the tendency, a sort of a psychological tendency to be impatient, to not, well, I go more in detail into it. And it has many sort of consequences in life on all areas. But anyway, genetics have that also, so it's not the better answer. But I'll go into a little bit more in detail about poor self-regulation, impulse control, novelty seeking, what I called very important in adolescence. You have to try new things to find out if they work and if they work for you. So what about self-regulation? Self-regulation is arguably at the top of the list of skills that we ought to encourage children to develop. In the Journal of American Medical Association from Pandy. Steinberg, I'm sorry. These are just some examples. Emotional lability, low frustration tolerance, lacking persistence, impatience. Short attention span. It's also one of the main criteria of ADHD, of course. Distractibility is also ADHD symptom. Restlessness, not being able to, delay of gratification. I'm going to show something about this little boy who's very interested in the marshmallows. Poor impulse control, acting before thinking, difficulty waiting. It's just some examples. I hope it's possible to have some sound also with, is that possible? I forgot to ask. It's a link to the internet. And I hope shall I try it? Oops. There should be some sound with it. I'm sorry, I forgot to ask you in the preparation. Let's enjoy.
Okay, sit in that chair. All right, here's the deal. Marshmallow for you. You can either wait, and I'll give you another one if you wait, or you can eat it now. When I come back, I'll give you another one, so then you'll have two. But stay in here, stay in the chair till I come back, okay? All right. I'm gonna go do something, and then I'll come back.
It smells yummy. Oh, it smells really good.
So it's up to you. You can have it now or you can wait. Okay? I'll be back. Stay in the chair, okay? Okay.
So I'm going to leave and then I'll come back, okay? So you can either eat it right now or you can wait. Either way, okay? Okay. How'd you do? Did you do good? You did? You wanted to eat it, didn't you? Yeah. So did I tell you I'd give you another one? Okay, I even have Bo. You need him.
So, super, thank you. Can you go back to the, oops, where were we? It's a good overview for remembering. So you must have recognized the infamous marshmallow test. And I thought it stemmed from the 1950s, but it's actually in the 1980s, 1990s, by a researcher called Shoda. I think he was. And there had been some critics on the marshmallow test. It's of course, well, basically it's a measure of either impulsive decision-making or delay discounting. That's the modern turn about it. To what extent do certain people, children, or certain individuals have a preference for relatively small but immediate gratifications, rewards, as opposed to delayed, bigger rewards? I'm quite sure that as a child I would have eaten the marshmallow within the first 30 seconds. So, because I was and am still a quite impulsive person. And what appears to be is that the delay of gratification is a good sort of, how do you say, predictor, so to speak, of addiction-like behavior, because addiction-like behavior is very much about immediate, preferring immediate gratification as opposed to, let's say, good health in the long run, for example. And we use computerized tasks that are basically not very different from this marshmallow test. I mean, it has algorithms and all kinds of risky gains and risky losses variations, but basically they're still based on something like the marshmallow test. Now, perhaps you heard from the Dunedin study, and that is one of the most famous studies ever done because it's a birth cohort. It was conducted in New Zealand by Terry Moffat and Absalom Caspi. And the special thing about the Dunedin study is that they were able to follow that birth cohort of a little bit more than 1,000 people in New Zealand up to 40 years later. And with nearly no, how do you say, fallout, no dropout of the cohort. So you have, and that is really rare, a sort of virtually a non-biased cohort. That is quite rare, and you can conclude many things about non-biased cohort studies. Can be confounders, etc., but it's a very, very exceptionally strong study. And what this study showed is that they looked, it's a birth cohort, so they, in the first 10 years of life, they rated the children, the 1,037 children, they rated them on a composition measure of self-control. Through tests, through observations, through questionnaires with mother and father, so a very, very reliable test about impulsiveness of the children. And they separated that composite measure of impulsiveness in quintiles, so in 5 proportions. And these are the 5 parts. The first group is the 1/5 group with the lowest self-control, second group, etc. And this is the 5th group is the group with the 5th part of the highest control in the early lives, so before the age of 10. And what you can see, and I already showed a little bit in the text, is that children with poor self-control had worse in this early phase, had worse outcomes in adulthood in nearly all life domains that they looked at. And perhaps even more important, this association, so bad self-control and poor outcomes in life, held at every point along the gradient. And that is what you can see. It's a linear association. So poor self-control was associated with more adult health problems, physical health problems, much more adult substance problems, both self-reported and collateral reported. Being rich or not, very low chance. A credit rating score on the credit card. High level of adult criminal conviction and even low levels of positive parenting to the next generation. So the negative consequences are even sort of distributed to the next generation again. So what this linear association means is that let's say the differences in self-control between the second and the first quintile is just as big as between the third and the second quintile, or between the fifth and the fourth quintile. So these are separate subgroups, but if you these subgroups also suggest that perhaps if you can change this level of self-control at the early years and make it one step upwards, that all children might be able to benefit from such an intervention. So I think that's crucial, and we could only base that on a non-biased sample of the Dunedin study. So if we can develop interventions aimed at improving that self-control, it may be effective in preventing these negative life outcomes. So even children with good self-control still could benefit to get a better self-control. So that's basically, and that would argue not for targeted interventions, but basically to universal interventions, and maybe something that we shouldn't even call an intervention, but just a life skill or a life lesson. That's the remainder of my presentation. So if you look at prevention, there is a classical sort of distinction between universal, selective, and indicated prevention, respectively targeted at a broad population regarding the risk status, some increased biological or psychological risk, and indicated, well, in the field of substance use, young people who use substances but have no substance use disorder. Well, what we see in the past decades is that universal prevention during adolescence is not very effective. Very small effect sizes. This is the effect size of Cohen's d. Or maybe you are familiar with that the lowest level, the small effect, is characterized by Cohen's d with an effect size of 0.20. This is even below that. And this ineffectiveness during adolescence of universal prevention has been the cause of an increasing evidence of selective and indicated prevention and treatment, early treatment also, has resulted in a shift in the past years towards more targeted intervention. And I wonder if that is justified, the shift from universal to targeted interventions. Perhaps we should look even earlier in life and then re-look at the role of universal interventions. And one of the systematic reviews and meta-analysis that I base my conclusion on is that of a Dutch colleague, Simone Onrust, from an institute in the Netherlands. And I think they were the ones for the first time that differentiated so school-based programs to reduce and prevent substance use in different age groups. They differentiated between universal and targeted interventions, but they also differentiated between these different age groups, so the developmental stage. And what they showed was quite surprising. It's a big study, nearly 500,000 participants in the meta-analysis, follow-up, even longer than 2 years. Most of the studies and programs were universal prevention with a minority targeted interventions. And they were all controlled studies, so they had a non-intervention control group. So quite strong design. And what this meta-analysis showed is that in the school years, So basically the pre- and elementary school targeted interventions were not significant, were not helpful, but the universal interventions, so offered to all children, were significantly effective, but again, here also a small effect size. I come back to that later, but still significant. Self-control, the major component, social skills, so basic skills in life. Healthy behaviors, problem solving. Early adolescence, so 12 to 13 years, both targeted interventions were effective and universal. Basically also the same basic skills as before, but with that added normative feedback. So ask an early adolescent, how does your alcohol use compare to that of your peers? Is that much higher? Or so this normative feedback is a quite important component of the prevention programs. And parent involvement is still possible at early adolescence. What the meta-analysis shows is that mid-adolescence is the worst time for prevention. Mid-adolescents don't have a message that they like from adults. They're not interested, they don't believe the adult, they don't believe the parent, and they're not receptive. If they are receptive, it's from peers. But even the peer education and the peer-assisted prevention programs did not result in significant effects. And lastly, the late adolescence. There you see that the other way around, that the universal programs are not effective, and the targeted interventions, and they're basically already really focused on early signs of substance use disorders, with motivational interviewing, with CBT-like interventions. But then again, perhaps you have heard of the prevention paradox. It was written on paper in the 1980s by, I think, an Oxford researcher, Geoffrey Rose. And the prevention paradox is as follows. Even small effects, if obtained in a large number of people at relatively low risk, think of universal programs, like all children at school, for example, may be of greater value from a public health point of view, so that's important, so for the whole population, from a public health point of view, than perhaps larger effects benefiting just a few people at high risk, like with targeted intervention or indicated prevention. So this is a very important paradox that is, I think, mentioned too little in the literature. So should we go revisit it? Universal prevention, revisit it. This is a series of studies of Desiree Murray, and it's like, you know, the thick meta-analysis and thick theoretic manuals about how children develop. It's about developmental psychology and developmental psychopathology. And what they show, and neuroscientists know that already, that during development, you can see from birth, there is no self-regulation in babies. It's all co-regulation by the care for, by mother, basically, and by father, not by the child itself. There's no self-regulation. The caregiver co-regulation, that's most important in the beginning of life. But then, let's say at preschool, so from the ages 3, 4, 5 years, there is a steep increase in learning curve. And you see a fast increase of self-regulation skills among children. They start to develop. Well, that would be, you know, a good period to intervene, and to, how do you say, offer good things to children. Well, it's always good to offer good things, but this is especially a good learning period. So preferably starting at really early ages, at pre-elementary school, at an age where the plasticity of the brain is still high. Children are very have adaptability, and self-regulation skills are still very much in development. But does it actually work already? Do we know something about it? This is a recent meta-analysis and we're close to the population that that I just spoke about, universal self-regulation based interventions in children, 49 studies, including 23,000 children and adolescents. Again, also controlled studies, so a strong design, with a pooled effect size of 0.40. So that's in between small to moderate effect already. It's a little bit a larger effect. But also much heterogeneity in the effect, so it's not robust enough. Quite a sort of mixture of types of interventions. Most were curriculum-based, nearly half were at school, were conducted at school. But there were also exercise-based or mindfulness or yoga-based or family, etc., etc. But still, good signs of evidence of that these universal self-regulation programs do work. Yes, this is what I found when I was preparing this presentation. This is quite a comparable meta-analysis of Blewit in JAMA Network Open, also from 2019, with a very comparable effect size. The other one was 0.40, 0.38, and this is in children 2 to 6 years old. So that is about the period that I spoke about with a very steep learning curve. Again, on very important proximal measures of functioning, so social competence, emotional competence, problem behaviors, self-regulation, and earlier, well, small to moderate effect sizes. And the nice thing about self-regulation is that it was also homogeneous, so a robust effect. So I think it's sufficient evidence that universal social-emotional learning, it has become the broad term that is talked about more often nowadays, shows significant improvement in a broad area of problem behavior compared with controls. Okay, I close this lecture with what is also important, and sometimes also good to know what does not work, and we should not put much more effort in it. And it's quite breaking news because it's a study that was published a couple of weeks ago by the group of Kuiken. It was published in a British medical journal, so it's a quite nice journal. A series of 3 publications of the Myriad cluster randomized trial. It's a really gigantic study that included 84 schools in England, Scotland, and Ireland, so the United Kingdom, cluster randomized to 2 times 42 schools, including more than 8,000 students at early adolescence. So perhaps not the most easy period in life to do prevention, such prevention intervention. Mindfulness training versus, well, treatment as usual, I should say, school as usual. Because the one group received, some lessons about life skills, but only as usual. That is not too much in England. And the other group, the experimental group, received the same, but including very intensive mindfulness training. Fully powered, rigorous trial, very high follow-up rate, excellent implementation, hypothesis-driven. I was very curious about what they found. No evidence whatsoever that mindfulness was superior to treatment as usual on any of the primary or secondary outcomes. No evidence of any beneficial moderation effect. So they found no, let's say, suggestions of subgroups that especially might benefit from yes or no for mindfulness. And they even found sub-findings that mindfulness might be contraindicated for students with already existing or emerging mental health problems, at worse depression and well-being outcomes in mindfulness than in treatment as usual. So I like to close, and this is one of the pictures, self-regulation station, about what is already done at school. Oh, there's a question.
There are some questions.
It was a quite intensive mindfulness training. Don't ask me for the details because I'm not an expert in that. It was for a nuclear period of about 12 weeks. The students could receive booster mindfulness training throughout the year and even over years. And the teachers were especially and very thoroughly trained in providing the mindfulness lessons. So it was really, and there was a high level of adherence even. Only the students didn't do their homework. But that's, I mean, basically what they never do. Also not in cognitive behavioral therapy. No, they don't do the homework there either. Okay, so my conclusion would be that lessons and exercises in, I call it essential life skills, including self-regulation and social skills and problem solving. How do I make friends when I'm a little bit shy? How can I delay my tendency to hit somebody when I'm angry and shout out, etc. Basic life skills. They should be routine and frequent part of, I think, the pre and elementary school. We have to really be at an early age. And should be offered, well, as universal prevention, but it should not have the character of an intervention even, to avoid stigma. Because that's what you have with targeted interventions always. There's a risk of stigma, and to promote that all children can benefit, right? You saw the curve of the Dunedin study. Even children with reasonably good self-control can benefit with even surplus self-control. So it's like lessons like geography, language, arithmetic that we learn at school, and life, just lessons in life skills, just as a normal part of the curriculum, 2 times a week, I don't know, 45 minutes each, and for 8 years in the elementary school curriculum. Children who benefit insufficiently, they could have a targeted intervention. And consistent implementation, because that's where it often goes wrong, and normalization of early intervention, prevention, targeted and improving self-regulation. It's not about prevention of substance use disorder, it's prevention of a wide array of problems that you can meet in life. And it's not for nothing that the big economic organization, in Dutch it's called OESO, the Organization of Economic Cooperation and Development, has invested millions in research in this type of intervention at early schools. So that's going to be a big development, I think, for the coming years. And it's not only about addiction, but a better life in general. I thank you for your attention.